So last but not least, we have Dr. Mahesh Shanmugam. He's going to talk about inflammatory retinal masquerades. Yep, yeah, I think that's fine. Yeah.
Morning and thank you. So let's start with this slide. This is a young child, about 5 years old, had vitritis and had undergone multiple vitrectomies, and this is how the fundus looks like. It looks like some kind of retinal infiltrates, possibly multiple patches of inflammatory retinal pathology. So, but then not all what that looks like retinal inflammations is retinal inflammation, as we can see. This child, when it presented to us, so this is how it presented. So it's under GA. We are just looking at it. The child had undergone 3 vitrectomies and a lensectomy for a diagnosis of endogenous endophthalmitis elsewhere, and they couldn't find anything. So we're just throwing a light there, and you can see those huge big cells floating around in the anterior chamber and multiple deposits on the surface of the iris. A simple AC tap showed that it was retinoblastoma. At the same time, we gave an intravitreal melphalan, and you can see how well the hypopyon has cleared up. So, and this is just immediately post the melphalan. So what is this retinoblastoma presenting differently? This is a diffuse anterior infiltrating retinoblastoma, and once the media cleared, this is how it appeared. So the retinoblastoma seeding onto the retina can mimic retinal infiltrates, can mimic inflammatory infiltrates, and can present with vitreous seeding mimicking vitritis. But the difference is that these cells are larger, and there's no anterior segment inflammation, and careful examination and imaging may show a small peripheral tumor. Diffuse anterior infiltrating retinoblastoma, you don't see a large big tumor with calcium. It could be extremely small tumor in the extremely anterior part, which may not be picked up very well with an ultrasound or an MRI. So we have to very, very carefully look at it and have a high degree of suspicion to suspect this. Let's look at another patient. This was a 65-year-old with loss of vision in both the eyes and had vitreous inflammation. So we resorted to vitrectomy, and post-vitrectomy you can see a frosted branch angiitis with retinal inflammatory signs. You can see, and there are multiple infiltrates all across the retina. You can see that's a frosted branch angiitis involving particularly the superior retinal vessels. And a cytology specimen was also taken during this time. And when we did neuroimaging, we found that the patient had infiltrates in the brain as well. So what are we looking at? We are looking at intraocular lymphoma. So in this particular patient had a CNS lymphoma with involvement of both the eyes, which can mimic retinal infiltrations, retinal inflammatory lesions. So 80% of the primary vitreoretinal lymphomas, where they present primarily with the eye lesion, will go on to develop CNS disease over follow-up. And those with CNS disease, like this patient, 20% of them will develop an eye involvement as well. So whenever we suspect a primary intraocular lymphoma and confirm it with a biopsy, then these patients have to be serially followed up to see if they are developing a neurological disease. But more often they present like this. This is a 68-year-old with bilateral vision loss and has been on treatment for posterior uveitis for 3 years. That's usually the history. The lymphoma is very difficult to diagnose. They will have vitreous cells, secondary retinal detachment, and vasculitis. But usually do a biopsy. So a simple syringe connected to the vitreous cutter is good enough to take a biopsy of the vitreous and then send it for a cytology. And sometimes we may have to aspirate the subretinal infiltrate, like what we're doing here. So surround that lesion with laser photocoagulation, and the subretinal or the deep retinal lesion is aspirated out and sent for cytology as well. In addition to doing a cytology, we can do an AC tap for cytokine profile. The IL-10 is usually increased in retinal lymphoma, so aqueous, and it serves as an aqueous marker for disease activity as well. So IL-10, IL-6 ratio of more than 1, then you would suspect a lymphoma. And OCT can also be helpful in diagnosing a lymphoma. So these are some of the OCT signs of a lymphoma. You will find this discrete pre-RPE nodules, subretinal band. You can see the outer retina being thickened, inner and outer retinal infiltrate, irregular retinal pigment epithelium, and diffuse vitreous cells. When you find them, then you would tend to think that this could be a lymphoma, not just a posterior uveitis. So how do we treat them? We treat them with intravitreal methotrexate or rituximab if it is just a primary intraocular lymphoma. If there is an associated systemic lymphoma or a CNS lymphoma, we treat them with systemic treatment, chemotherapy, external beam radiation therapy, in addition to treating locally as well. So here is another 25-year-old lady who presents with bilateral optic disc involvement and what looks like retinal inflammation involving the posterior pole, and with some amount of tortuosity of the vessels. So is this inflammatory lesion of the retina? Actually, this is how she presented, with bilateral hypopyon. What is different about this hypopyon? You can see there is not much of a conjunctival congestion or a circumcorneal congestion, and this hypopyon has a convex upper border and appears to be composed of larger cells and doesn't shift easily when you make the patient lie down to one side. So a simple AC tap confirmed the diagnosis of a leukemic infiltration of the eye. So they can present, leukemic infiltrates can present like this. So how do we treat them? We treat them with systemic leukemic therapy, and if it doesn't respond, then the eyes may have to be treated with radiation. This is the post-treatment. You can see the infiltrates have resolved, and of course there is optic atrophy in one eye, but both the eyes, the patient is able to see better. On the other hand, this was an 18-year-old on treatment for leukemia presented with this infiltrates. So the oncologist wanted to know if this was a leukemic infiltrate, because if it is a recurrence of the leukemia, then he wanted to upstage the disease and advise total radiation and bone marrow transplant in this particular patient. So we needed to know if it was indeed a leukemic infiltrate. So we had to resort to a biopsy. So here, despite the patient having a very good vision, you can see a normal macula. We induced the posterior iris detachment, then did laser photocoagulation around the infiltrate, and we had to do a biopsy. So a diathermy is done around the lesion to be biopsied. Then with the scissors, the retina is cut, a small localized retinectomy is done, and we enlarge the sclerotomy so that the tissue can come out without macerating it, and using a bimanual technique, we cut that piece of the retina and maybe the underlying choroid and remove it. So this was transferred to the other forceps and removed out of the eye and sent for cytology. Unfortunately, this turned out to be an infective infiltrate rather than a leukemic infiltrate, so the patient did not have to undergo a bone marrow biopsy. This was a 35-year-old lady who presented with something like a retinal inflammatory lesion involving the disc and the peripapillary retina, and associated with an inferior temporal branch retinal vein occlusion. So what are we looking at? Actually, this is an optic disc and retinal metastasis from a carcinoma breast. She had actually undergone a bilateral mastectomy many years back. So this is how she presented. She went on to progress like this, having a combined central retinal artery occlusion and vein occlusion, despite the fact that she was on treatment for a metastatic disease. So we had to treat her with intravitreal chemotherapy, and the lesion regressed subsequently, but then of course the vision was lost by the time, and of course she succumbed to the disease in about 3 months' time. So this is a 3-year-old with decreased vision with exotropia, and right eye had count fingers close to vision, and this was the lesion. We're not too sure if it was involving the retina or the choroid, because it was not very cooperative for the OCT as well. And retinoblastoma is something which had to be ruled out as well. So here we went ahead and did a biopsy, because ultimately that is the only way we can get some diagnosis out of this child. So again, a vitrectomy, PVD induction. Then here a retinochoroidal biopsy was done. So initially the retinal tissue was removed and sent for the histopathology, and the underlying choroid was also removed. You can see again a bimanual technique. So this tissue was sent for biopsy because there was a retinal infiltration. But actually this was a very rare diagnosis of a ganglioneuroma of the choroid with retinal invasion. This is a benign tumor, so treated with transpapillary thermotherapy subsequently. On the other hand, this was a 26-year-old lady with bilateral loss of vision of 15 days and had a spontaneous abortion, was suspected to have toxoplasma and treated with toxoplasma treatment, and also with oral oricoronazole amoxicillin. So I see this retinal infiltrate continuing to worsen despite the treatment. So a diagnostic and therapeutic vitrectomy was done in both the eyes, but the specimen was negative for fungi and bacteria. So we empirically treated the patient with intravitreal antibiotics and antifungals and oral antifungals as well, for about the next 5 months along with some amount of steroids, and you can see the lesions resolving. Actually, it's an endogenous endophthalmitis because of the spontaneous abortion as well as the intravenous, probably the fluids which were given. Another patient, last patient, 49-year-old, 6 months loss of vision, had this anti-toxo treatment, and it was stopped, and the patient continued to be on systemic steroids. But you can see the toxo titers were still high. So what had happened is the toxo antibiotics was stopped much ahead of what it should be. But on the other hand, the systemic steroids were continued. So the disease presented differently with the persisting retinitis. So we restarted the anti-toxo treatment, and this is how it was post-treatment. So to summarize, neoplastic lesions may mimic inflammatory retinitis, life-threatening systemic malignancies or ocular malignancies. High degree of suspicion and appropriate investigation, including a biopsy, would be required. And infective retinitis may present differently if treated inappropriately. Thank you so much for your kind attention.
Thank you very much for the excellent cases. Any comments or questions from the floor?
Thank you, that was excellent. I had a question about the lymphoma patients that you diagnose. So when we do diagnostic vitrectomies for these lymphoma patients and we find lymphoma in the eye but not in the brain, how do you go about treating them with methotrexate? What is your protocol, and how often do you screen them for CNS disease?
Yeah, one of the things which we need to do before we do the biopsy is to stop the steroids for about 2 weeks, which is something which I forgot to mention, so that we get a better yield. So the treatment schedule is not like the original schedule which is being advised. So here we do a weekly injection for 1 month, then bi-weekly for 1 month, then once a month for the next 10 months. So that's the schedule which I follow. It's either rituximab or methotrexate. I have found some patients not responding to rituximab and switch to methotrexate, they seem to respond well. As far as the CNS lymphoma is concerned, initially I would probably screen them once in a year. Initial baseline screening is done, then once in a year. As the disease probably, as years go by, then a more frequent screening may be required.
Yes.
So how common we can pick the retinal infiltrates of lymphoma on OCT?
Whenever it's a primary intraocular lymphoma and the media is clear enough, I would suggest doing this OCT. So there are those classic signs of the outer retinal layer being thickened, because many times you can mistake this to be a wet age-related macular degeneration.
Yes,
you can
sir.
mistake this to be...
They resemble the drusen.
Exactly. Yeah, you can mistaken to be that. So you will find this inflammation in the vitreous and the outer retinal layer thickening. That's something which seems to be classic for a lymphoma. So I used it quite often if the media is clear enough for us to allow an OCT.
Secondly, sir, in every case, that is MRI should be done to rule out lymphoma,
Definitely,
CNS
yes.
lymphoma.
Yes, a MRI of the brain and the spine should be done.
Okay, sir. Thank you, sir.
Sir, I just want to ask a simple question. In general practice, we don't see these cases very often, right? For example, I'm stating if a person is not specifically a VR specialist, let's say a person is just practicing medical retina along with cataract surgery or something like that. So these cases might not be very common. So when this kind of a patient comes to you, usually your first diagnosis is posterior uveitis or something like that. So what are the clinical signs, or what are the things that should basically make a person suspect intraocular lymphoma in the first stage itself? Because usually a person will, if you have a heavy OPD volume, you would just regard it as a posterior uveitis and send the patient away. So what are the things that should basically light a bulb in your head that this might be something else other than posterior uveitis?
Agreed. Yeah, one is the age group. So usually about 50-60 years of age is one. Bilateral uveitis you have, including the vitreous inflammation, as well as you would find the retinal or choroidal. Now, there's no choroidal inflammation in the sense like what we look at primary intraocular lymphoma. You will find a vitreous inflammation and some retinal infiltrates. So these are what can be. So like basic investigations we do to rule out tuberculosis as well as sarcoidosis. Those are things which we rule out. Despite which, if the patient continues to be there, sometimes it could be after a therapeutic trial. You treat the patient with steroids, and these patients are resistant. They get better, then you start tapering the steroids, they have like recurrence of inflammation. So even if you don't have the initial time suspicion, when the patient keeps recurring or recalcitrant disease, then you need to think that whether you're looking at a lymphoma. And one of the things is, as I mentioned, the OCT. So OCT, when you do these signs, what I showed, if you find them, then once again suspect a lymphoma.
And uveitic profile you would have done already for the patient. And so the first thing when you suspect is go for a contrast MRI straight away?
Not necessary, as I mentioned. So if in case it fits into this category, a bilateral uveitis which is not fitting into your usual uveitis profile, then is when I would think of doing an MRI, because only about like 20% of the patients may have the CNS lymphoma when they present to you. So 80% will not have; they will develop subsequently. So you're doing an MRI initially may not be diagnostic. We need to suspect a primary intracranial lymphoma and prove it by doing a vitreous biopsy, and only then you would probably think of doing an MRI.
Last thing, for the panel before the session closes, regarding the second talk on wet CNV, if you could comment on the real life results of Paganex versus Eylea in your chronic resistant cases. If you could provide some insights into that, that would be helpful. Before the session closes, of course, after the talk.
Sure. We'll do that at the wind up. I think Dr. Gupta has standing here for a question on this talk. Yeah.
I wanted to know, you had a very good pathology backup, and I can't find a very good pathology backup. So do you send it somewhere, or do you recommend any chain where you can get this kind of diagnosis?
Earlier we didn't have an in-house pathologist. We have been having an in-house pathologist for the last 6 months only. Earlier we used to send to this Anand Labs, which is there in Bangalore. So the key is to take a good specimen, stop the steroids and transport it as early as possible, and then speak to the pathologist and send it across to them. So despite which many times you may land up to be negative. And if it's a cell block which is prepared, then I would send it to an established center like Shankar Nethralaya. So I would usually send it for a second opinion. Once a cell block is prepared, this specimen can be stored and like another opinion can be taken. So I would usually send it to Shankar Nethralaya for another opinion, and in addition to doing a local pathology.
And any chain you can recommend where we can send it? There are multiple chains available.
You can, as I mentioned, like if you have prepared a cell block or slides are there, you can send it to Shankar Nethralaya, Dr. Krishna Kumar for another opinion. I'm sure he tells you.
Thank you, sir.
Last question, I think if any patient who develops about the Masquerade, any patient who develops the uveitis after first time, after 50 years of age, I think one should always think of the Masquerade disease.
I would agree.
Anybody after 50. So second question, can we do supposing if you don't want to do the extensive for PIOL, intraocular lymphoma, can we just do the vitreous tap in the OPD? Not the biopsy, I'm not saying the full biopsy.
I would not be comfortable because like there is a risk of little detachment because of sucking the vitreous out. So it's better to use a vitreous cutter and take a biopsy rather than using a needle.
You don't want to take him to the OT and all and do the OPD.
I would be comfortable using a vitreous cutter to take a biopsy.
I think, sir, since we are dealing with a potentially life-threatening condition, it's probably best done in a theatre setting where everything else is controlled. And the other question for someone in general practice, I think if there's something that doesn't fit, just send it to someone else, take another opinion, and if both of you feel it doesn't fit, then we send it to a third person. Your question was on faricimab or Paganex in resistant CNV. Yeah, I think it's a question of resistance versus comfort level versus explaining to the patient there's a remote risk of inflammation with any of the new anti-VEGFs. So I think ultimately one would have to take a call. Has the drug been given in the protocol that it was intended to be given? Is the follow-up good? Have you actually seen the way it's responding before you decide to switch? Sometimes switching happens too early and then you really don't know what works. So